Good evening. This is the second meeting of the Inner West London Mental Health Services Reconfiguration Joint Health Overview and Scrutiny Committee. This committee was established jointly between Westminster City Council and Kensington and Chelsea to independently scrutinise the substantial reconfiguration of local NHS mental health services. In addition to the Vice Chair, Councillor Knight, I'm delighted to have Councillors Arundel, Dean, Siren, and Councillor Ahmed on this committee. I'm pleased to see the Cabinet Member and Lead Member from the local authorities, Professor Manthorpe, and the Lead Member from the local authorities, represented from the NHS and Health Watch here with us this evening. Thank you. Tonight, the committee will be considering the work programme, reviewing and providing comment on sections of the pre-consultation business case, and hearing from residents' contributions. Item 3, apologies for absence. The second item on the agenda is the apologies for absence. I note that Councillor Mona Ahmed has sent her apologies and I have received no others. Have we received any other apology? Thank you. Item 3, declarations of interest. We will now move on to item 3, declarations of interest. Could I please ask attendees if they have any declarations of interest to make? Okay. On page 11, there's an action at the last meeting. Maud Murdoch, Chief Executive of CNW, said she would provide clarification on how much of the 2.3 billion award was spent in each borough. Can I ask if there are any representatives from CNW and North West London ICB for an update on this item? We haven't received it.
So I think that's an apologies from us. You have been sort of chasing Claire for that, and I think it should have been directed to us. But Claire doesn't have the sort of detailed information on that. Your governance officers came to me sort of earlier in the week to chase it, and I'm going to sort of hunt it down for you in very short order.
Do we have a timeline on that?
Yeah, end of next week.
End of next week. Sure.
I just have one thing on the money, because I think one other thing that came up at the meeting was the Grenfell money, the 50 million that was allocated to the Grenfell recovery in Kensington. And we talked about getting a breakdown of this and where that was spent. And I know Murdoch said, we need to protect the privacy of residents and bereaved and survivors. And, to be honest, I've had a conversation with a number of people in the community and no one seems to have this information, including the bereaved and survivors. So could we add that as an action point as well, please?
I'm happy for that together. Thank you. Okay, just move on to the minutes. The members agreed to the minutes of the previous meeting held on the 11th of December as correct recording of the proceedings. On to item 5 of the work programme. The work programme report sets out the committee's work programme for the last scheduled meeting on the 23rd of January. That's possibly tentative. Do members have any comments on this?
Sorry, just in terms of the timescale.
Yes, the work programme, what we've got within the work programme.
Well, where is the issue? I don't know if it comes in here or not. Is that
I think we should consider extending the whole process. I don't know if that fits in at this particular time, but I think that we're rushing this process somewhat because there are quite large chunks of the community that have not been consulted that would be directly impacted.
When you say the process, can you be a bit more specific?
I mean, we have a deadline for finishing this consultation process. So yeah, so I think that should be extended at least a month.
May I respond on that?
Yes, please.
Because we have always said that we wanted this consultation process to be an iterative process, in that we go out and we speak to one group of residents, one people who are representing residents and stakeholders, and many of those will then suggest more people we need to speak to and so on. And so we've already had a discussion amongst ourselves earlier in the week, and we're consequently minded to extend the consultation by 2 and a bit weeks to the 16th of February. So we are already in a position of thinking that that is what we need to do. We can have a further discussion over whether you think the 16th of February is the right date, but we've already reached the conclusion that there's further time to have further discussions with these groups of residents, and in particular to then allow some of these groups of residents time to reflect on what we have said and respond, which should be something that we should do.
Are there any particular groups of residents that you have engaged in that has made you think that the 16th of February, 2 weeks, is the right timescale, and those are the groups that you want to speak with?
So it is that's sort of specific. The answer to that is no. There are quite a wide ranging. So there have been some groups of professionals we've spoken to who have said, we would like you to come and speak to us on this, and the date that they suggested has been towards the end of January. And there have been residents in North Kensington through some of the routes we've reached, who are again come back and said we would quite like you to come and speak to us directly on this before, and we are holding is on this particular date again towards the end of January. Some of the estates in the south of Westminster, and particularly Pimlico and Millbank, again have suggested that we come and speak to them towards the end of January. And we've just reached the conclusion that it was unrealistic and unfair to present to them on in the last week of January and then expect a meaningful response back by the end of January.
I'll just say that even that timescale, if you're seeing them towards the end of January and then you're going to finish 2 weeks later, I would be thinking in terms of allowing at least 2 opportunities to meet, an introductory meeting and then a follow-up one, so people have a better idea of what's on offer and what their views are on it. And also, there's still quite a significant community that you haven't actually reached yet, which I've said before is the homeless community, amongst which there's a lot of mental health. And I don't know if you need to speak to them directly or to the people who work with them, but I haven't seen that covered at all in anything that I've read. And I think that's going to require a bit of work, so more than 2 weeks.
Thank you, Paul. Take a look at that.
Sorry, just one more question on this, and I'm sure we'll come on to talk about the consultation more fully, but are we allowed to know which groups these are that you're going to be visiting? Because I did have a call around some of the, PCS, but also some of the partners who are delivering some of these services. And, I was quite disappointed to hear that none of them have been engaged with so far on the consultation, which I find really alarming. They also have large groups of service users who they also feel haven't been included. And when you look at the way the consultation's been done, I worry that there are large groups that are excluded, and particularly the very unwell groups. The people actually who need the beds that we're sat in this room discussing, they don't want to go to an online meeting. They don't want to go to a community meeting where they're not with people that can support them, and they certainly aren't in a position to fill out questionnaires. So I feel that there is a large group of people who actually are directly impacted by what we're doing here and talking about here that we haven't reached at all.
Okay. So I'm more than happy to supply you with the list of groups we have reached out to and through. I would be surprised and indeed somewhat alarmed that there are significant groups of the like you described, which we haven't reached. if that is indeed the case, then we need to reach them, and that's very, very simple.
We also have the numbers of how many have been attending these workshops, because there's been sort of.
So we can give you,
Like
we can give you the
next
numbers of so how many people we've reached out to, and so how many they responded. So you can see sort of both the ones that had the opportunity to and the response rate.
And the ones who've been sitting and engaging in those meetings, just because if it's 2 people going to a meeting, that's not particularly effective. Engaged meeting.
I think it was just to add that we have certainly through November and December, we've done a number of focus groups with homeless networks. So we have actually already included it in the work we've been doing as part of the consultation. However, you know, absolutely, if there are other groups and other work that we can do to build on that, then we will keep doing that. So we've met with homeless networks, we've met with staff, and I think we've met with a number of GPs as well working with the homeless. But equally, you know, we absolutely, you know, want to hear the feedback and want to sort of build on that and do more. So take that on board as well.
I mean, I can tell you the people I've spoken to who, you know, are really key people delivering these services in Kensington and particularly North Kensington. And they told me they have not been engaged with. I mean, people like, well, for example, Melanie Wolf, who, you know, is part of the local account group, she sent a question to the last meeting. You know, there was a commitment from Claire that she would be reached out to and that actually we would all go and visit her in her food bank. I mean, she's been working with very mentally unwell people for the last 4 years, and I've been there, we've seen these people, but she hasn't had anything. And the meeting happened, you know, a month ago. So
Great, I think we'd have to challenge that point, but we have a we have a meeting scheduled in Kensington Community Kitchen for the 17th of January. So that is for, I haven't called it out previously, but that is for one of the groups we know we need to engage with. We have a time scheduled to do that, and we are going to go and speak to them.
And who is going to go and speak to them?
Probably me, but we haven't quite finalised the which of our cast of people is going to go and speak to them.
Can I ask which groups in South Westminster, Pimlico area that you've consulted with regarding the homeless?
So I don't have that to hand. I could probably get.
We specifically met with the joint homelessness team. That's supplied works with that whole area, and they're based at Vauxhall Bridge Road.
Okay, so the council's homeless team.
This is the joint team between the council and CNWL.
Do you think it's important to get input from the actual homeless people and the staff that work with them in terms of their mental health?
So yes, we have engaged with those staff and got their feedback.
So I see there's a meeting schedule at St James the Less
Yes.
in about a week or two.
Yeah.
Have you also engaged the Abbey, because they have like a soup kitchen at the Abbey where there will be a significant number of homeless people and staff who work there?
They have the weekly feeding session for homeless people, and I'm a trustee there lately.
Great. Let's just commit to getting you the list of all the people we have engaged with. We've made the commitment previously that if there are people that you feel are missing from that list, we will go and engage with them.
Okay.
You have an absolute commitment from us.
That's great.
But we want to go and hear from all of these communities, staff, residents, from all of these groups in a way in which they feel able to feed back to us.
Okay.
And if that means that if we give you that list and there are people who we think we should have spoken to, we have not spoken to, we will go and speak to them. If that means we have to extend the consultation timetable in order to do that, that is what we will do.
Okay. Just quickly on that point, on the meetings that you have coming up in the next week or two, there are, I think, about 6 of them or so at St Charles, so that's a number of them. When did you get those advertised, and how are you advertising them to residents and groups?
So the advertisement should have gone out before Christmas, and they've been sort of followed up subsequently, and they come out through our email lists, they come out through posters in our GP surgeries, they come out through posters in just about all of our NHS facilities. We started sort of doing the promotion through sort of social media, so sort of TikTok, Facebook, and so on. And we speak to the sort of the homelessness teams and so on. So the teams are actually working directly with the staff and the outreach groups to so they can pass it on to the people whom they know. We send out the circulars. We send out circulars to all of the community and faith groups, housing associations, which we know, so that they can promote them to sort of their members and to their contacts. So we were been working alongside the local authorities or communication departments to make use of your channels as well. So I think we've had quite a broad range of trying to get sort of the message out.
Okay, that's great. Thank you.
I'm just going back to what Alan said in terms of service users and those who might be more vulnerable and not wanting to attend these meetings and not in a position to filling out this form. How can we do that in the most gentle way that we do hit these people, because their input is crucial into actually understanding feedback from people who might be using the form right now.
Yeah, so again, it is a sort of naturally a sort of mix of sort of different methods. So yes, we do invite them to do sort of consultation, the community meetings, and all of the other things, because I don't think we can take the assumption that all of them don't want to sort of feedback through those particular means. But over and above that, we are working through a number of these sort of groups to set up or piggyback upon sort of the meetings which they are already holding in the communities, so that we can come and speak to people in the locations where they feel most comfortable talking to us. So the Kensington Community Kitchen would be an example of that. So sort of Melanie is working with us to bring to work with her sort of the people she works with, so that we can go out and speak to them in the community kitchen, which is the place they would sort of normally sort of come to and get their sort of responses that way.
Okay.
It's probably considered as worthwhile adding that in all the communication there is a telephone number that if people just want to have a conversation and put their feedback in that way, they can speak to one of the team to give that information.
We're also holding the groups sort of with sort of existing sort of current sort of patients in the in St Charles and our other sort of facilities, because again that is that are obviously people who would be affected by the proposals, and we have the opportunity to speak to them sort of while they are in sort of contact with our services. And I have to say, it is not universal that everybody wants to speak to us about on their experience, as unfortunately so you would expect. But we are doing our utmost to sort of reach everybody who should be able to respond through channels which allow them to respond. And again, so I am absolutely all ears if you have sort of further suggestions or better ways which we can do that, because this isn't going to work unless we hear back from all of the people we want to hear back from, and that I think it's incumbent upon all of us, particularly upon us, but upon all of us, to support that happening.
Thank you.
So just one point before, just to go back to what you were saying about the numbers of people who are coming to these group sessions. When do you think you might be able to give those to us? And also, do you have a feel for how many are coming? Because again, I mean, I've spoken to people who have attended a couple of these sessions, and it wasn't. I mean, it wasn't great feedback I heard, to be honest with you. 2 separate locations. I mean, one was at the Pepperpot, which is actually in your consultation document. Apparently, it didn't even happen. Somebody turned up and was told this consultation is not happening in the Pepperpot. They were put in the Westway Trust. I mean, anybody who knows anything about North Kensington knows you do not hold a consultation in the Westway Trust. It was in a small room. It wasn't signposted. I mean, that's not a consultation. And, there was another example, actually, in the Westminster side, I heard from this service user, and not even somebody who's that well known in the community. I mean, she said there were 7 people in the meeting. And not only that, she said that there was one person that was, she lived very close to the Gordon Hospital. I don't want to talk about individual cases or anything, but she didn't feel she was being allowed to speak, and I'm really worried when I hear this, and I'm not hearing it from one place. I hear it from lots of different places, VCS partners, users, service users, and people actually delivering the services. So I'm concerned. I really am concerned.
Okay. Then obviously we have work to do to allay your concerns on this. It is So generally true that sort of services like sort of mental health services, you when one goes out to sort of consult and hold sort of community meetings, not that many people come forward to the community meetings for all the reasons you have already sort of laid out. So they are not the most effective channel. Now they are a necessary channel, so we have to hold the community meetings, but they are not the most effective channel. The more effective channels are going to speaking to people in the environments within which sort of they are comfortable rather than.
How many of those have you done? I mean, tell us, you're talking about Melanie in a week's time. How many like that have happened? Because I haven't heard of any, and
We'll give you the we'll give you the list, and it is sort of north of, it's somewhere between sort of 30 and 40 at this particular sort of period of time, and
Okay.
with more scheduled over the coming weeks.
Just because we've spent a fair bit of time on this item, I just want to sort of move on from this item to.
Order. I think going backwards, I'm missing from the.
No, that's the old one.
That's the old one. Okay, all right.
Okay, the other questions around specifically the consultation and the conclusion of that and the timeframe that we will then receive the feedback. I know we're now looking at possibly moving things, so you're not going to have a date, but you might have a timeframe within which you will do the work and then get back to us what that feedback looks like. Do you have an idea of what that?
So we can give you the consultation report sort of 6 weeks after we close the consultation. So on the assumption that we close it on the 16th of February, which is an assumption at this point given the discussion we've already had, and that would give you the sort of consultation report on about the 29th of March. Now, the 29th of March is within the pre-mayoral election sort of sensitivity period. So I would anticipate you would not be wanting to hold one of these meetings until after the mayoral election. So that would suggest that the JOS, which we consider the consultation report, would therefore happen in May. Were we to extend the consultation by another sort of 2 weeks, 4 weeks later, it would still give you the report during that pre-election sensitivity period. So again, I would anticipate you would then want to hold the JOS to consider it at the same period and somewhere in May. The knock-on effect of that for our sort of decision-making timetable is that our board, so the following board meeting for the Integrated Care Board after that is on the 16th of July. And that is where we have to then sort of propose or taking the sort of final decision. Now, so Jackie has made me aware that you would want to hold a sort of subsequent meeting to our decision making, sort of meeting to consider sort of your response to the decision which we would make, and that you would not wish to hold during the school holidays, which start on sort of the 19th of July. So we have still a little bit of choreography to do to ensure that sort of that works for both you and for us. So either we need to make a decision slightly earlier, so you can consider matters before the school holidays, or we need to make a commitment not to do anything until, well, so you've got time to come back after the school holidays and consider your position. So I haven't yet worked that through, but I am working that through.
Understand. Thank you. Okay. Move on to item 6. And this is our focus on the business case, and just to give you a briefing of some of the key items that we'll be looking at for this meeting tonight. We'll be looking at the impact on partner organisations, enhanced provision for those in crisis, clinical quality, implications for service users, assessment of options, embedding of findings, principles from the voice exchange report, a model for the new MCAS, options, appraisal, process and engagement, and consultation, communication and activities. We will, I would first like to invite Councillor Butler Thalasis to speak on the impact of the options on Westminster City Council, as well as the impact on partners, social care, the DCS and community provision. We'll then hear from Councillor Rendell about the impact on Kensington and Chelsea Council and the wider impacts.
Okay, So the first thing I wanted to say is that it's been very interesting listening to this discussion about how to ensure that more people are consulted with. But as far as I'm concerned, a bigger problem is the quality of the consultation documents, which I think is very poor and very biased. So when you look at the consultation document, the case it sets out is that the current circumstances are great, that currently we have an excellent system and we want to tweak it and make it even better. And that is not something that is the view of anyone who is not CNWL or the ICB. So we have talked to we've talked to our own social workers, we've talked to our housing teams, we've talked to other partners, and this is not the situation that that anyone believes to be the case. So, for example, there is a claim here that there is a 30% drop in monthly admissions. That might be true. I mean, if you have fewer beds, you admit fewer people. Our own data in the council is that if you compare data from 22-23 to the previous year, we are assessing more people, and of those people who we are assessing, more people need acute hospital care. So our data shows an increase in need, not a decrease. And I also wanted to say that, because I think giving numbers and quotes verbally can be hard, but if you want any written statement afterwards of the things I say, we can provide a written response, which might be easier. We have also seen an increase in the numbers of people. Obviously, Westminster residents are all out of borough, but also the numbers who are of Kensington and Chelsea users who are out of Kensington and Chelsea in other hospitals outside St Charles. In both boroughs, we have seen an increase in the number of suicides. So the information we have is not that the current situation is a good one. We have had meetings with the people who run the A&E in St Mary's, who have told us how extremely difficult the situation is there, with people with mental health needs having to stay for a very long time waiting for beds. We've heard from the police how much time they spend escorting people, and how much more time consuming it is, but much more distressing it is for patients. Obviously our own social workers, when someone is out of borough, they have to travel much further to support them, which wastes a lot more time than when they were able to pop over at the Gordon. We have heard from other services like Look Ahead, who have said how difficult it is to hold patients who need to be admitted, as they have had to hold them for longer and longer and longer until they become very, very distressed, and how hard this has been. So I'm just saying that the universal view outside the mental health services is that currently we're facing a mental health crisis, and services are not meeting the needs of the people. Additionally, I would say that, so that's the general gist of the consultation document, but then there's the actual questionnaire that people have to fill in, which obviously gives huge prominence to option 3 and says, option 3, this is what we want to do, come on, come with us. And then the description of option 1, for example, describes itself of, if you went for option 1, then community services would be cut. And the phrase cut is used for community services. There's no mention of the 51 beds cut that has happened 2 years ago and has happened already. At the same time, there is another quote that it asks people to support. It says it gives you an option. Thank you very much. On different statements that you could agree with. One of the statements on option 6 says, I would prefer inpatient care closer to where I live, even if the quality is not so good, such as shared bathrooms and limited outside space, and it does not meet national standards. I think no person can tick a box that says, I would like to have care where the quality is not so good and does not meet national standards. Now, I know that I have raised this point many times, and the argument is that this refers to the national standards regarding shared bathrooms and an outside space. However, this is mentioned as an example in the statement. It doesn't say, and this is the only aspect of quality that this doesn't meet. So when you read that, as far as you're concerned, it could mean, wrong medication, people who are not qualified treating you. You have no idea what this care that doesn't meet national standards would be on. So I think that the quality of the consultation documents is so poor and so biased that I think that the results of the consultation are not to be taken seriously. Additionally, I wanted to make a point about this space in the Gordon Hospital. Now, it's clear because mental health staff have told us many times that mental health staff find the Gordon a difficult environment to work in. That doesn't mean that it is a poor experience for patients. It might mean that additional staff required, that it's more expensive. But in terms of the outside space, the Gordon Hospital had a rooftop garden. If you compare it to St. Charles, one ward has an outside space. All the other wards, the only space that they have are these balconies, which are essentially a bit of mesh. And if you stand next to them, you can feel some air from the outside world. That's it. So the notion that the facilities in St. Charles are vastly better than the Gordon is not true, although I appreciate that it might be a better environment for staff to work in. The other point about the shared bathrooms, of course, it would be much better for people not to share bathrooms, but we have so many facilities where people have to share bathrooms. Not only across the country, many mental hospitals have shared bathrooms, but also all our supported accommodation for mental health service users, where people might stay for 2 years, not 28 days, have shared bathrooms. So the idea that these are the pinnacle of why we cannot use the Gordon is not the case. So yeah, I think these are the main points I want to make. Thank you.
Thank you.
Thank you, Chair. No, thank you. And thank you to Jessica for summing that up really, really well, and really such passion. From our point of view in Kingston Chelsea, as you know, both Jessica and I have put out a preferred option that we think is the best, which is option 1. Even though we don't wholeheartedly support option 1, I think it's the best options that are available compared to what the previous service was. Now, we could have easily gone out and said another option 4, for example, but that would not be particularly constructive whatsoever. So we are definitely thinking that option 1, which perfectly sums up in this document, which is certainly not the preferred option. And I think that is very, very clear in this document, even though you take 31 pages of this before you get to it, which is not particularly accessible to do that. In terms of impact on Kingston and Chelsea, which is your question, Chair, as well, how it affects others, I'll just give you some facts and figures that we've got, which I think the committee may find extremely useful. So, for example, prior to the temporary closure of the Gordon Hospital, 94% of Kingston and Chelsea residents that needed mental health support would go to the St. Charles Hospital. Now, 76% go outside of the borough. And that is a huge impact on people's day-to-day lives and what they need. We think obviously a lack of beds will worsen people's support and outcome and experience. It also increasingly the likelihood of police involvement as well, which is also we don't want. That's the last resort, and people need help they need at first point of call, not the very last point of call when there may be potential issues down the track. And again, I think option 1 kind of reflects that the best way we can. Just in some other facts and figures, Chair, if I may. So, for example, over a 6-month period, from June to November last year, 31 Westminster residents were sent to St. Charles, but 1 was sent to Norwich. That would not have happened, I don't think, if the current service or the service provided in option 1 was available. In the same time period, in the Kingston and Chelsea residents, 20 residents were sent to out of borough hospital services for mental health provision, with 1 going to Milton Keynes in July 2023. Again, people who need to be close to their family, their friends, their support network, being sent far away, from Westminster case in Norwich and RBKC to Milton Keynes, is not a particularly prime example of good healthcare, I think. And the option provided would, I think, third option would continue to exacerbate that, I must say, which again is not a really good use of other people's time, I would say. In the period since the Gordon has been closed, the percentage of patients admitted to or detained out of borough settings, again, not in the Gordon or in St Charles, quadrupled from 6% to 23%. I mean, again, a huge number from affecting all our residents and all our patients here. And but KNC residents, admissions to St Charles dropped from 94% to 76% because, of course, you know, residents here are now competing with the Westminster residents who need it just as much as well. So again, having a further impact, people are having to rely on other support networks in order to get their help or going further afield. Now, it's not just, you know, acute beds or you know, services that we need. I think what the option does, option one also does, which is what we also disagree with, it also sees the community services also withdrawn or lowered or discontinued. Again, it's not the best case scenario we can hope for, but it's the option that we think is the best. But again, with people not utilising services in either the Gordon or St Charles, those community services can't be provided if that's what the consultation finds. Because if people are going elsewhere, they can't get the community support here, and so it's a bit of a double whammy. People are getting knocked twice for no fault of their own, just because of the service. Just to sum up, Chair, I think the options in the consultation make residents choose between inpatient and community services, as I said. I think this is really unacceptable. They actually need both. The way the consultation is worded suggests that the decision has already been made, as I said, option 3, which is, yeah, and it says that in question 1, our preferred option is option 3. We do not believe our health and wellbeing order, the GSNA that we have put together jointly as two boroughs, especially in the needs of Grenfell and the aftermath of the tower, has really been taken into account. I mean, I know we're 6-7 years on from the tragedy, but there is still real community concern, especially if the tower comes down, if that's the decision that is made. For that, there's no provision of those mental health services that are needed. And that won't just affect bereavement survivors, that will affect the entire community, not just in North Kensington, but also in northern parts of Westminster as well. And that is not accounted for. I don't see anything that has come to the fact that the tragedy, such as Grenfell, an international tragedy, has actually been taken into account in any of this. And if it was, then none of these options would be available. But this is where we are. Also, we still have not received CNWL's assessment of the impact on council services, nor received an analysis of demand that we asked CNW for numerous times, I must say. The CNWL representative may say something about that, but also that's really disappointing from where we are, because we're kind of trying to take guesswork here in the dark, and we've asked for data, we've asked for information, we've not received it. So we've tried to work as best way we can, and that's Karen and I have written numerous letters to CNWL over the course of last year, and not received a response, I think, on some certain questions that we've put forward as well. Happy to take any questions you may have.
Thank you both. You just said. I am now going to move to members and committee members to look at some things that you said. But before I start, just sort of in the interest of time and effectiveness, if we can stick to 2 questions maximum at a time each time, and then we'll move on, and I'll come back to and follow your replies if they can be as succinct as possible, but also forward to ensure that we get what's necessary. Okay, thank you. Councillor Dean, I'll start with you.
I was looking at Appendix 17, the NECOS model. Last week, I was very fortunate to be able to visit St Mary's Hospital with Professor Jim Orchard. And while I was there, I was to see the Lighthouse facility. And I must say, I was extremely impressed by the calming, welcoming atmosphere of the unit, which is operational 24/7. Well done. However, speaking to the professor, he said because of the exclusion criteria, the occupancy rate was already more than 2 out of the 4 rooms at any one time. And that made me think of, looking at this attendings. I'm really worried about these exclusion criteria that you have here. And is that going to affect the meetups at the Gordon? And is it going to be worthwhile looking at these criteria to change them so that we can get a higher occupancy of rooms? I'm particularly thinking about people with autism, because that's what I know about best. And I know that if my son was in an accident, an emergency setting, I would want him to be taken to the lighthouse. But under your criteria, he would not be.
So just to talk to that directly, it's purely around safety. There has to be safe operating models that are put in place. So in terms of the exclusion criteria that are put in, it's around the staffing levels that we have within the lighthouse and the expertise that we have within that space. So the current exclusion criteria sit there to make sure that anyone who's transferred there that doesn't have any physical needs that needs to be attended to, that's because we move them out of the A&E department away from there. So that's the first and most important one. The second then is around any behavioural disturbance that the person has at the time. And so then we have to be able to have a sufficiently large enough team to be able to manage someone safely in those instances. So in terms of what we have available in that lighthouse space, there's limited funding for the staffing.
Could you not put in more funding so that you can make better use of this wonderful facility?
Well, funding's not mine. Purview.
Well,
mine turns to Toby.
So that's the answer to that is obviously, so yes, one could, but within the funding envelope which we have, that inevitably means that we have to move the funding from somewhere else. So it's this constant sort of balance question. Indeed, the balance question is very much at the heart of the consultation, because within the funding envelope we have, where are we best sort of deploying that money?
Underutilising such a wonderful facility is very good, very upsetting.
Can I come in, Councillor Dean? So it's something that I'm very passionate about. I've been involved from the start of the development of the Lighthouse service. It's a new provision, and part of something being new means that there's an iterative process to bring staff on board, to bring our liaison teams on board, to work out who's the best type of patient that will really benefit from that experience. So yesterday we had 4, the day before I think we had 5 people come through the unit. So it is constantly evolving and changing. As it only moved to 24-hour provision in December of this year. Up till that point it had operated 8 to 8. So we're looking at the model and augmenting it all the time to make sure we get maximum use for patients. And
that's wanting to make sure you can do it at MCAS as well, because these criteria
and MCAS is a very different provision, which has got medical staffing in it and allows us to take a much greater level of risk. So the MCAS that we have at the minute operates at capacity, and the proposals are to open a larger one to allow more people to benefit from it.
Thank you. Thank you. And just for sort of following some of the agenda items, I want to look at the impact on partner organisations specifically for this bit. We do have a section on the MCAS coming, so I'm sure there'll be more questions on that we can add later. So just hold it for now and we'll come back to that. But just to sort of carry on along the works programme so we can get through that. Do you have any questions specifically on the impact on partner organisations?
So I wanted to raise a couple of things here. I had a conversation with, and by the way, I have permission to raise these concerns in this meeting, and the people I've spoken to are happy for their names to be put against these comments. I had a conversation with Amelia Mustafa, who runs SMART, who, as you know, is responsible for taking care of the most unwell people that we have in our borough, and I think parts of Westminster as well. I mean, she told me that no one has called her about the impact on her through the closure of the Gordon Hospital. Again, I feel she also told me that she's asked for data on the impact of the closure on service users, and she's never received anything from the NHS. So I just want to raise this and have it in the meeting notes, and we can follow up on this, but I would like to have that information. And actually, I think somebody like her, who really is on the front line and I'm not on the front line, I'm just a councillor, but when someone like that who has worked so hard in our borough for so long, through very difficult times, says that to me, my initial thought is, she needs to be involved in the consultation and in the options and in delivering what we need to deliver at the end of all of this. And the fact that she feels excluded and not involved and her voice hasn't been heard really concerns me. And she didn't even really know about these meetings. So, you're saying that it's all going on Twitter and she didn't know about it. Somebody like that who has such a big responsibility for delivering these services. She made some other comments too on the consultation, which I'll include here. And we talked about co-production, which is something, that I was quite involved in when I was, the lead member for adult social care and the lead member for communities, in Kensington and Chelsea. And she very much feels that this consultation needs to be a co-production with the very unwell people, but also, all service users. And, her organisation has the tools to do that. And some of the other VCS, because, to be honest, I spoke with Angela Spence, who is from a social council who supports our VCS, some of which are also operating in Westminster. And she also told me that nobody has spoken to her about the impact of the Gordon Hospital. And we talk about community care and, all these people, and it really sounds very nice. And, it's what we want. Of course, you don't want people in hospitals. But if you've got somebody like Angela, who really is, the kind of beating heart of our VCS, and no one has called her, and I've got no reason to suspect that she's not telling me the truth, that kind of raises some very serious questions for me. So I guess what I would like to bring out of this meeting is people like Angela, Amelia, Mind, the BME Health Forum. These people need to be involved in this conversation. So maybe we need to invite them to the next meeting. Maybe we need to invite them to, give their thoughts and feedback. Because I don't think they've been included. And I think an important part of scrutiny, our scrutiny, and there will be partners in Westminster, I'm sure, is that those voices are all heard, not just with the model, but with the consultation and in all the conversations we're having. So, thank you.
Councillor Arundel?
So just two quick things. So a resident who wasn't able to come today at the last minute is asking whichever of the options are chosen finally, what provisions will be in place at the Gordon to prevent past experiences in terms of decades of antisocial behaviour amongst the local neighbourhood, which is a direct result of the policy of care in the community and away from beds in the Gordon. And my other question or point is towards the two speakers. I totally resonate with everything that you said. And do you have an idea of what would be the ideal solution, or what would be close to an ideal solution?
It's very simple.
You go.
I think the ideal solution would be to keep the community services as they are, to reopen the Gordon Hospital and to put not the same, a different MCAS in the Gordon Hospital. Well, hey.
The same number of beds that were there before.
Yeah, absolutely. And Nafska and I completely politically aligned to this as well, because that will not only impact benefit Westminster residents, but also for Kensington and Chelsea residents as well. And this is central London we're talking about. We're not talking about some community which has a smaller population. We're talking about, a global city that needs proper support, especially in an increasing mental health crisis. So your question, Council, is absolutely right. That's something that we both agree on, both politically and in terms of our policy, is what Nafska has suggested. And that's the best case scenario. And that's hopefully what we're pushing for, even given the options. But that would be it.
Thank you.
So my last bit of the question.
So before you carry on, can I just pass that over to Graham, based on the 3 points that's been raised? How does that sound to you?
In terms of reopening a hospital in Westminster?
Well, the exact 3 things that Nafska, do you want to repeat them?
Reopen the Gordon with the same number of beds as previously, stick an MCAS in there, I don't know, on the roof, and also keep the community services as they are now.
So I think my immediate reaction to that is it's not affordable, but also the building would not be safe for the sorts of patients that we're talking about, and that's a conversation that can happen, that we don't think it's a safe or effective place to house inpatient care for the sorts of patients that we manage now.
It was, I mean, even your consultation documents say reopening the Gordon would be safe. It wouldn't be, the quality of care wouldn't be as we would like it to be, but it would be safe. That's what the consultation says.
It would be minimally safe for an extortionate amount of cost.
Be good to have those figures to understand exactly what you mean when you say that. That could be one thing.
So, yeah,
This is the
the options appraisal does talk through the sort of financial numbers at the highest level. When the sort of Gordon was the inpatient wards, the Gordon were temporarily closed at the sort of start of the pandemic, and we did not sort of sit on the money and put it into some form of suspense account and sort of not spend it. We redeployed that money to build the community services, and indeed with the mental health investment standard, we went sort of over and above that and invested sort of more money into sort of Kensington, Chelsea, and sort of Westminster. So this is the central point of the consultation, is that we have a choice to make, and within that sort of finite sort of financial envelope, what is the best configuration of services for the residents of Kensington, Chelsea, Westminster. The consultation document, I think, quite unapologetically makes clear we have a view on what we think that best configuration of services is, and that's indeed why it states there's a preferred option. I think it would have been disingenuous of us not to put forward quite clearly in the consultation document what our preferred option is and why we believe that to be the preferred option. But it does mean that if we reopen the beds in the Gordon, we have to move the staff. So when the Gordon beds were closed, those staff were moved to support community services. If we reopen the Gordon beds, we have to move some of those staff back, and that has a consequent effect on the community services. And we can run that through in terms of some monetary numbers as well. But that is the case. We have a choice here. We can debate about where on the spectrum we come down, but there is a choice.
Okay, just before you jump in, and that's based on, so pick up what you said, Graham, affordability.
So it is based upon a number of things. So the first thing it is based on is the national evidence and or direction of travel that we should be treating residents in the least restrictive setting, which is appropriate for those residents. So you've got on the list of things to talk through is on the voice exchange sort of report, and it's not the only sort of report we have from residents as well, but there is a substantial group of residents who feel particularly traumatised by inpatient care and feel that they would benefit, and indeed the evidence from the Royal College of Psychiatrists and so on will demonstrate that people get better faster when they are sort of closer to home in community settings. Now, not everybody. There will always be people for whom an inpatient setting is the most appropriate setting. And those need their sort of inpatient care. But as the treatment has developed over time, as our understanding of how to improve people's path to recovery has improved over time, our ability to better serve people and support them to recover faster in community settings has improved. And that is at the heart of our reasoning here. More people will get better faster if we can treat them in community settings and not in an inpatient setting. So that's sort of rationale number one. So rationale number two is indeed sort of linked to the cost. But that is because an inpatient bed costs a lot more to run than treatment in the community. And that enables us to reach far more people by taking the money which is in inpatient settings and putting it into community settings. So the number of people being able to serve in the community has gone up 3-4-fold since 2019-20.
Are these
That's
acute
over.
patients? Can I be clear?
These are acute patients. They're the acute patients. They've gone up to 3/4. We've got more on talking therapies and all of that as well, but particularly for those presenting with an acute mental health need, the number of those we've been able to serve has gone up to 3/4 during this. Then we come to the slightly narrower point on the money around what's actually affordable. But what we have tried very hard to do is to make this case stand up on the basis of what is best for residents and what is best for those who are experiencing episode of acute sort of mental ill health, and not to focus on what the monetary constraints not to focus on the monetary constraints. And that's how the monetary constraints are real, and that's why we have a choice to make. But we have tried very hard to make this stand up on the basis of what is best for residents in terms of the care which is appropriate for them, and what is best for residents in terms of improving access for them, and not to be driven by the money.
Okay, thank you. So I'll pick up on your point, Councillor Bassett, and you can ask your next question. And then Lucy, there we are.
I mean, I think the gist of it is that the assertion that more people are being treated now than there were previously is not something that meets the experience of anybody who does not work in the mental health service. Normally, we are being told that you can, for one person treated in a hospital, you can treat 44 people in the community. So presumably, the money invested from the Gordon Hospital should have created community services that would have resolved every mental health problem out there. And instead, what we have seen is that the mental health problems in the community amongst our residents have gotten worse progressively. So that's the situation out there. So in my view, the community services that are being paid for by the money that was used from the Gordon are clearly not good enough and are completely inefficient if all that money is being spent for these services that are not doing what they are meant to be doing. Additionally, we have been told that there is additional investment in the community. I think 2.3 million additionally that has been spent locally for community services, and that money should be spent for community services whatever we do with the Gordon Hospital. So it should not be an option that if we reopen the Gordon, all community services have to close, because that money is specifically for community services. So I'm just saying the money as it's currently being used is completely inefficient.
Do you want to add before?
No, I was just going to say that, just reiterating the point on the money, as I said earlier, Chair, was that the assessment from CNWL of the impact that the decision currently stands or will have on council services. So when we're going to speak about money, and that will affect the ICB or CNWL bottom line, but it has an impact on our local services. And as we know, as both boroughs, funding and services are really, really tight and really, really strict. So it's just moving one problem from one place to another. And we legally can't provide health services as a council. That has to go through someone else, but that's no impact elsewhere on any other service provided, especially in the social care sector. So I understand the point about money. I do. We all council team. We do have to have an eye on books as well. But at the same time, that will have an impact on us elsewhere as well, and that will resolve the problem. That will actually make it worse. Make it worse for the community setting. Make it worse for residents in our borough, both boroughs. That will need to rely more and more on council services, and we don't have that impact assessment from CNWL, which I'm asking again for, if they may. Thank you.
Could I just maximise point?
Really quickly.
So one, I don't fully understand that argument, because would we be saying that we keep people in the highly restrictive setting of an inpatient ward with locked doors with a high level of staffing provision to look after their care at the cost of over £600 a night, just because we don't want to then move them into at least back into their communities to have at least less restrictive form of care? So I don't think that's the right thing to do for people. So whatever we should be doing across the system, we should all be working together to make sure people are back out of locked environments.
No, absolutely, that's right. But not if if they need it, then they need your service, then you're saying they don't.
So we know that across our system at any one time, a large number of people are clinically ready for discharge who are waiting for services in the community, wouldn't need to have to be in that locked environment if we were providing enough in the community for them. So that is a continuous problem. That was a problem before. We know that the very long lengths of stay we had in Gordon before were a large part of that. What we're trying to do with this new model of care is to have alternatives for them to manage their crisis in the community, so they're not having to go to those locked environments in the first place, because that's not the appropriate way to respond to a social crisis. The other thing to say is also about the additional community investment. I think it's a good point that Councillor Velasquez makes. There was additional funding that came down separately, so we must separate the two things out. There's funding that came down centrally from the for the NHS long-term plan, which is the mental health investment standard. That would stay whatever option we do. So those communities, the uplift in community team staffing that happened through that missed monies, that would stay whichever option we chose. What we're saying with the choice within these options is the crisis alternatives that we have available within that. And we explain those within the consultation document of which ones those are, which would have to be the choice between the two.
Very briefly, just to say, our housing support services are always talking about people being inappropriately discharged from hospital too soon before they are ready for community services.
That's really helpful. Arundel.
Okay, so I understand the point about obviously you're balancing. You've got a choice of options within a certain framework, but I'm thinking that the framework is incorrect, because you don't operate in a bubble. Come to my ward near the Gordon Hospital, and weigh up the damage done by people who are not properly cared for, who've been dumped in lots of people in one building, for example, and the impact of calling out the police service 13 times in one day for one person who's having a crisis, and there's no proper care for that person. What's that in money terms? What's the impact on the neighbours? What's the impact on a family when the father has to move away for 6 months because they might get bottled by the person who's not managing well in the community? What's the impact of people keep continuously taking the person suffering from mental health to court because they threw a bottle at them, or they urinated over their doorstep or something like that? What is, how are you going to separate that off from what you're talking about, a limited, I mean, it's not limited, but your sphere, your bubble. But there are wider things to consider. And I think those things should have been added to the report. I don't think it should be a separate thing. I think those things should have been included. They do have an impact. And money saved in police time could, there could be a juggling of overall funds, and you might get more money out of it if police aren't having to spend 50% of their time attending to issues that arise from mental health problems.
I think that would be a very hard thing to separate out, because you actually, as we were talking to before, so we've got a 300% increase in how many people we're trying to help in the community now. So we've got a 300% increase in how many people we are now helping in the community. So we're doing far more work with people in their communities and trying to help them there in that space. Now, is there a huge demand out there for mental health services? Yes, there always was. And we always said to serve every single thing that goes on in society? No, it's a really complex situation. Sometimes the most appropriate response is the criminal justice system, because sometimes that's antisocial behaviour, and that's not what mental health is equipped to deal with. And I can't comment on individual cases without actually seeing them. It's complex. But within this new model, at least we have expanded the amount of provision we've got. More people are getting help from services than there were back in 2019.
That's not it. It's ASB resulting from people with mental health problems who don't have the correct care. So they're doing stuff that they don't have any control over, and the correct care is not there, and that impacts on everybody in the neighbourhood, in the block, or whatever. It's not about, I don't think you're getting what I'm saying. It's really related to mental health and nothing else. If they were treated properly, we wouldn't have these mental health issues. We wouldn't have the police coming out non-stop several times a day for one person. It's a major issue that shouldn't be ignored.
Can I just very briefly? So I know we've said this before, and I get that we have a difference in our data, and I think there is a reason for the difference in our data. But if someone needs an acute mental health bed, they will get an acute mental health bed. Acute mental health patients. Well, let me come back to that point because I hear what you're saying. We will guarantee that an individual gets into a bed when they need it. Now, what we are seeing is a fall in the number of our local residents that are going into acute beds. Not a huge fall, but it is on a downward trajectory. And a lot of that is driven by the support that we have in the community. But if there is someone that is in the community that may be causing antisocial behaviour or other things that demonstrates they're in crisis and they are assessed as requiring a bed, they will get one and they will move into that bed.
But
Now,
they won't be assessed as needing. The police will come out and say, oh, it's mental health. We can't interfere. The housing team will say, leave him alone. It's mental health issues. Leave him alone. They will not get assessed for an acute bed.
If the police come out and they think it's mental health, then they would use Section 136 of the Mental Health Act and they would bring them to health-based place of safety for assessment. And we have the police have shared the figures on the use of that act, so it does very clearly happen. But I hear your point about we do as a CNWL system. We will use beds within our hospital system because we want to get people into bed as quickly as possible. So it does mean that we don't always get people into St Charles that we would want to get into St Charles, but we're addressing our capacity elsewhere to make sure that our local residents are on the majority of time going into St Charles. But we can't talk about individual cases. We do need to remember, though, that sometimes there are safeguarding reasons or other things that might mean it's actually better for an individual who, for example, might be a staff member in our trust, and we have agreements with other hospitals to allow us to get them treatment elsewhere, or there might be someone known to the community. So without going into any individual matters, there are sometimes very genuine reasons why it's right for the individual that they get treated in a different place. But my final point, Councillor Arundel, is that we have seen the fall in admissions. We, though, as I said, we will guarantee a bed. For the last 12 months, we have not treated any resident outside of our hospital system. So we will get a bed for them and they will be within one of our hospitals. It's not to say it will always be St Charles. That's what we're aiming for, but we've not treated any resident inappropriately outside of the hospital.
What are you calling your hospital system? Are you calling that Milton Keynes and the CNWL, or what is
the vast majority? The very vast majority will be treated within one of our London hospitals. There are occasions when we would use Milton Keynes. That could potentially be a staff member, another safeguarding reason. But the vast majority we will have treated within one of our London hospitals. So that's
also important, I think, to do some of the comparison because on the numbers. So we sent 12 residents of Kensington, Chelsea and Westminster to Milton Keynes in 2018-19. In the last full year, 2022-2023, we sent 9. Now 9 is still too many. But 12 to 9 is a move in the right direction, and that coincides with the reduction of the number of beds with the sort of temporary sort of closure of the Gordon wards. So there is an issue there. I'm not going to sort of shy away from the fact that there is an issue, but it has been getting better alongside the closure of the beds of the Gordon. It has not been deteriorating.
Why are we seeing an increase in the number of people being assessed and the number of people who need to be detained?
Yeah, so this is, I have to say, a slight mystery to us at the moment. So, and we are trying to work with David Bellow and your hands to sort of iron this out. So if we look at the numbers, then broadly, the number of assessments and the sort of number of sort of Section 2 referrals, that's normally the first sort of referrals which one gets for a sort of community assessment. In Kensington and Chelsea have been sort of broadly flat. If you look at the sort of the numbers for Westminster, what you see from 2018-19, we take that as the base year, so before the Gordon closed, to the last full year, 2022-23, they have gone up quite sharply on the numbers from the AMPs. Because about 70% of my calculation, but it's a bit difficult to tell because there's an overnight team where you can't tell which are Kensington and which are Westminster. So there's some sort of noise in the data. So we can see that, and you can see that, and that's the basis of the numbers which you've got. However, if we look at the people who have been referred to CNWL, who are residents of Westminster under Section 2, we do not see the same increase. Now, that's the people who've been referred, not the people who've been admitted. So there is a discrepancy between these numbers, and that's the bit we are still trying to get to the bottom of. Now, there are various hypotheses for why there could be a discrepancy. So part of it will be that the AMP assessments take place on residents of your boroughs as well as what non-residents of the boroughs. And so residents were never admitted into the Gordon. They're repatriated, sorry, non-residents were never admitted into the Gordon. Freudian slip there. So non-residents were never admitted into the Gordon. They would be, if they were from Lambeth, we try and send them back to Lambeth. And part of it is that the AMP assessments include people under the age of 18 who had never been eligible for Gordon, and people over the age of 65, older adults, who had never been eligible for Gordon. So part of it might be that. So the next dot down the list is that sometimes you repeat assessments on the AMP. So it may be that there's been an increase in the repetition of this. I don't know what that is.
I'm sure
but we are trying our utmost to get to the bottom.
100% Westminster residents. I'm sure non-residents were sometimes treated in the Gordon.
I just interrupt me. I feel as if some of the answers are quite long and we're not able to move on. So I'm so glad. But thank you. I think we've kind of covered that. Thank you.
I was actually just going to take us back to Appendix 9 on the voice exchange, and wanted to start by saying that there were some concerns highlighted throughout this report on the quality, availability and effectiveness of community services. And for example, in patient F's contribution to the report, they state that there are no connections or correlations between the bodies and agencies. And that was one area of serious concern for them. So my question to you is, from this type of feedback, and there was a fair amount of feedback like that, how can we be confident that your option C, which is heavily reliant on partnerships with BCSD organisations and good communication between bodies, is the right option? How can we be feeling good about that when there is feedback there? They're just, and even from what Anne's been saying tonight, that people have not even heard or have been spoken about yet. How can there be that trust, even from the get-go of this relationship? And how can we feel confident in it, even here tonight, when there's feedback like that, and from today?
So our service has been in the process of transforming it the last 2 years. It seemed to be a trailblazer site for the to mention. So we went ahead of most other places in the country, Westminster being both first and KNC very shortly thereafter. So they've been on a transformation journey over the last 2 years. So the point when this voice exchange report was produced, that was at the very early stages of that transformation, when we were only just about reforming our own place, bringing in the new recruited staff. So there's been a large change since then. So we've now got to the point where we can see that the numbers of people that we're managing to see through those teams is massively increased, as I was describing before. We know that the outcomes that we're seeing through them are improving compared to what they were before. We know that the friends and family tests, the results that we're getting back are highly positive about the services that are receiving within them. We're more than happy to share that information with you if you'd like to see that for those assurance purposes.
Yeah. I mean, I hadn't even heard when I sort of was looking at that yesterday about Anne's conversations today, but I mean, even getting on the right foot going into this, that's not a great start. That a lot of these community members and organisations feel left out of this process already. Got one more point on that before. Okay.
Sorry, Ross, did you want to respond to that? Was that a new question?
It was on that question, actually, if that's okay. So I think it was just recognising that voice exchange wasn't just a point in time report. So we've continued that work on an ongoing basis, and we've continued to support the consultation. You know, the sorts of recommendations that they made around training and supporting staff, embedding lived experience, community-wide approaches, keeping listening. They're things that we try to build into the whole transformation of community services in North West London. So that's why, for example, we've got service user and carer representative in our borough leadership teams. That's why we embed it in the work that we do. It's why we drive, you know, deep kind of project work that we do with particular community groups and third sector. Just on Anne's point around Angela from Smart. I did just want to say very quickly on that. So we have tried to literally, pursue all channels for engaging with different parts of the system, all of the channels available to CNWL and all of the ones available to the ICB. And we have weekly stand-ups with our council colleagues as well. If we've missed out Angela from SMART, my apologies. We will. Sorry, Amelia. But the other things that you mentioned, Anne, was, so some of the other organisations like the BME Forum, Mind, and so on. So we have, done focus groups with Mind and the BME Forum and Action on Disability, the Middle Eastern Women's Group, French African Group at Canalside House, and a number. And so I think it's just, I wouldn't want you to think that we're not trying to do this, but I think we are also dependent on our partners to help connect us if there are people.
But these are the two most important partners that we work with in Kensington and Chelsea, and no one has called them. And actually, I mean, it brings up 2 points, if I may, Chair.
So if we just make it one, that would be really helpful.
Okay.
Thank you.
You're using a marketing engagement company to do this consultation verb. Again, there are some concerns about using an organisation like that, because many of these people that you want to reach are traumatised, have mental health problems, and these people are not necessarily trained to manage and talk to these people. And I've seen this myself in community events that we did after Grenfell. You've got to be really careful who speaks to these residents and people with these issues. I heard some concerns about that organisation, and I think it's that organisation that have called Melanie. It's not the NHS or CNWL. And again, I don't think that's very appropriate, for everything that Melanie's doing in the kitchen, that she's called by a marketing engagement company. That's not the right person to call her, basically.
It's really well made point. Ross, really.
Okay, well, just to say, not a marketing agency. They're an organisation that specialises in supporting public consultation work like this. However, I do take your point, Anne, and actually, if there's additional sensitivities that we need to take on board about some of those contacts, then we'll do that. But these are people
community,
who
you send them a
these are
agency.
they support public consultations all over the country, and they are experts in that.
They have not gone down well, is all I can tell you.
Okay.
Thank you. Listen, do you want to finish your?
One last point on that report, and it's just something that really jumped out to me from reading it, is how often it was raised that there was no compassion in our mental health services. I mean, it was quite jarring reading some of the accounts of how staff were treating patients. I mean, there was one account of someone saying they should man up, and some of the language I just found, and I know you can say this was taken back from 2021, but that should never be how patients are treated, and the amount that could exacerbate their situation is, I mean, I don't even want to think about it, but it made me think about whatever goes on from the option that's chosen for this consultation. How can we address staffing that if it's an MCAS, if it's the Gordon in inpatient beds, because empathy and compassion in terms of services is, I mean, paramount in the fact if we're not employing the right people, and if our staff feel overworked and that's why they're treating patients appallingly, we might as well sort of scrap their entire care they're giving, because they could be making someone feel 10 times worse than they are. So I just want to understand, if it's the MCAS, if it's an inpatient centre, how are you going to change this? Because that document, even if it was in 2021, that's not okay what people were going through. And the last point I want to make on that, and see what you have to say about it, is one husband said that when his wife went into care, I think at St. Charles or the Gordon, he was completely shut out. So he had no connection. And to him, he was really trying to make an example of the fact he should have been the first person they should have been speaking to, so that they had a benchmark of how well if his wife was getting better, and the fact that that wasn't even part of the treatment plan. And if it's not a husband or a wife, it should be someone in the community or some reference. And how he's trying to bring that up. I want to understand how that's going to change, because it's very concerning.
I could not agree with you more. But whenever I hear reports of that kind, I find it utterly shocking. And there's no subject that's close to my heart I'm more passionate about in mental health services than about the way that we engage and to have compassion for people we work with. And in my 20 years now that I've been working in mental health care, I have seen far too many occasions when we're below the standard we need to see. One of the things, so you're asking how we're going to do it differently, we need to do something different this time. And within South Westminster, we're doing a pilot of something called Open Dialogue, which is a model from Finland, and this is family systemic in its orientation. It's one of the first in the world that we're doing in terms of doing it at this scale. And it is all about asking first who's important to you, not what's wrong with you, what's happened to you. It's focusing on bringing in those important around someone first. We're now about halfway through the training for the staff around those South Westminster teams. Been going through that. It's a long and complex process to change a culture, and to get to reskill staff with new sets of skills around that. It's a process that I think is going well so far, and we're building towards those changes that we're seeing with those teams. We're also looking at what other models of shorter training we can bring in for larger numbers of staff around. So including things like staff at the MCAS, now looking at something called Just Listening, which is something we're bringing from Australia, which Matt Ball, who's an international nurse, winner of the Year award, who has a model of care which is about doing justice to listening, and he trains communities who are far away about how they can support each other around it, and making sure. And he starts with the staff learning how to sit with people and sit with their distress. But it's really difficult, challenging work at times, particularly when some of those most acute points of distress, as we've been talking about here tonight. So we're not sitting back on previous ways of working. We are constantly trying to innovate, and we're investing in trying to upskill our staff and look after them. It's one of the number one things which I found very encouraging that came through that voice exchange report was they said, how are you looking after your staff? Because if you look after them, they'll look after us. So we're very much taking that on board, and we're doing a lot of work around that.
But also with that, in terms of looking after your staff, there's always also going to be a demand for their workload, and this is what we're all talking about. So if it's the MCAS and it's completely overwhelmed, you can look after them as much as you can, but it's going to be their work.
And MCAS hasn't been overwhelmed.
No, I mean, I'm talking about if the MCAS couldn't handle the shortage of beds, and just generally what we're speaking about tonight is, yeah, okay. Thank you.
These are decisions operationally we have to make all the time about what does demand look like right now. How do we then think about, do we need to temporarily move the resource from one place to another to meet those needs? But it's something that we monitor daily, hourly, even in terms of where people are and how you can best utilize our resources.
Thank you.
And just picking up on that point, when you say your staff, to be clear on who are your staff, what sections of your staff are you referring to in this instance for the open dialogue training?
So that is, it doesn't matter any background in terms of professional status or otherwise, of any banding level. We're including it from senior managers all the way down to support staff at from the lowest bandings of pay, everyone in between. We have made sure that we've also included service users and carers as well on that training, so their voices are real alongside the staff members as they debate and understand the ideas involved.
And how are you testing this, and how are you prioritising who gets this training? Because you've got a huge staff team.
So it was offered out to all the staff members within those teams. We've got the majority of it. So there was about a third of them went through the training last year, and then we've now, with the current lots who are on the training this time, the majority are there. There are a certain number who've chosen not to take advantage of the training this time, but we're going to put another cohort on later this year again. So let's try and see if we can find a way to bring the remainder with us as well.
I mean, with it being such fundamental change, I'm just thinking of what Councillor Bunton and Councillor Rendell has said, especially you might think that one of the things that could be helpful is ensuring that staff do engage instead of it being an optional training if we are looking at changing the way that things work and then work.
Can I just build on what Gareth has said? So this is something that we're working really hard to pilot and evidence in South Westminster. It is something we intend, based on the outcomes of the pilot, but we do intend to roll out across the trust, but that's not the only thing we're doing. So we also are developing our approach to trauma-informed care, so people understanding why someone is behaving the way they are, not just dealing with the behaviour in front of them. And we are a trust that's signed up to the Triangle of Care as well. So this is in response to Councillor Knight mentioning about people saying their carers and loved ones aren't involved. So we have a very active carers council who are holding us to account and holding me to account. I'm the exec sponsor for them, but we meet regularly on how we can really improve that dialogue across the whole trust with our carers and make sure they're fully involved.
Thank you. I'll just summarise some of what I think we've heard tonight, and then I'm going to ask my question at the end. Started off with Councillor Blassis, focusing on what she believes to be a poor and biased consultation. And the only people who seem to agree that this is a good consultation are people in CNWO or possibly some of the ICE also. This has been increase in need, but a decrease in beds. An increase in number of people out of our provision. We had figures from that from Councillor Brendel. An increase in suicide rates, an increase in A&E use for people with mental health needs, an increase in police escorting people, social workers travelling further, which has been quite inefficient in terms of the way services are working, engaging with places like Look Ahead, and the difficulties that come for patients being held who are facing mental health crises, and the services that they need. Looking at the options as well, option 3 and 1, and the big difference between these, and what's actually necessary. Then we moved on to talk about, in RBKC, looking specifically at previously, before the closing of the board, and 94% of RBKC residents would get to go to St Charles, but now 76% of patients are out of borough, which is
no, just I think that's the figures I have. So it's
I think it's 76% are in St Charles.
Yeah.
Now,
so it's still a decrease. Okay, but not.
1965 and 7%.
Okay, nice. Thank you for correcting that. If you do find anything different, Councillor Rendell, listen to us.
Yes.
And of course, using out of, not just out of London, but out of London provision, and also your network not being specifically Westminster and RBKC, but beyond that, so London more specifically and wider. Increase in admissions and what that looks like, and community services being withdrawn, though we need possibly more. And also the options that they came up with, the 3 main points around what an ideal looks like, but however, that doesn't seem to work for you in terms of the options that you put forward. And then, of course, the Grenfell and the aftermath, and specifically so what's not being taken into account around that as well. And there also seems to be a theme around not receiving data that's been promised to us, and also similarly questions that's been asked and emailed from both Councillor Blassis and Councillor Rendell, and that hasn't come through. And I think ensuring that changes would be really helpful, so that we can ensure the process is fair and we are being sort of conscientious about all of it. My question specifically is around A&E and how you're managing this, especially so with the increase in people being unwell turning up to A&E. And that's happening now with all of the different things you're saying that you put in and are putting in. How do you sort of justify that?
So there's a couple of things here, I think, Council Chair. One, you sort of listed a long number of charges or sort of points from new members and sort of chairs of health wellbeing boards. I don't know whether this is the appropriate moment to go through those one by one and give a response, but I suspect it would take sort of the rest of the meeting sort of were we to do so. But I have to say, for quite a number of those things, so we would not recognise, or we would think that we would say that the proposals are deliberately sort of crafted to respond to. And I do think it's important that we at some point take time to sort of work our way through those and see how the proposals sort of respond to those particular points. So I'm open to whether you want us to try and do that now, or you just want me to respond to you, or we can write
If you can
to
respond
you,
to
we
my
can write,
question as well as then the more
Yeah.
robust document that you're suggesting.
Yeah,
would
okay,
be helpful.
okay, so we can do that. So on sort of accident and emergency, so for the sort of cohort of sort of residents who would go into the cohort, so 18 to 65, we have not actually seen an increase in presentations to accident and emergency for those patients. For those patients, we have seen an increase in Westminster. We've seen a decrease in RBKC, and if you take the two together, it about sort of nets out. What we have undoubtedly seen, though, is an increase in the amount of time people with mental health diagnoses spend in accident and emergency. So that we have definitely seen. It has to also be said, across this time period, we've seen a significant increase in the amount of time people with physical health sort of needs have spent in A&E. And indeed, if you look at the percentage increase, the increase in the amount of the number of people who spend longer than 12 hours in A&E with a physical health need has increased faster than the amount of time that people with a sort of mental health need. So it's against a backdrop of a sort of problem across the health service, but overall, sort of moving people on with mental health needs does not deteriorated as fast as for those with sort of physical health needs. Now, that is obviously not going to satisfy. It is a true point, but it is not going to satisfy. So what we then get on to is how can we move those people who've got mental health needs faster out of accident and emergency. So there
So
are.
can I just interrupt you quickly? Beyond just moving them out faster, it's more people actually attending accident and emergency.
Not with mental health needs.
But in Westminster,
In
you
Westminster,
said yes.
I mean,
In Westminster, that is
you
true.
clearly said that there isn't in RBKC, but the RBKC doesn't have an accident and emergency. That is in Westminster.
So, okay, no, fine. So the numbers gone up in Westminster, it's gone down in RBKC, but we've always run the two boroughs as a single system. So the demand which sort of presents has always been balanced between the sort of facilities in the north of the boroughs, the facilities in the south. If you go back to slightly over 20 years, the facility in the north was in Westminster and not in RBKC, and it moved when we sort of refurbished St Charles. So it has always been a bi-borough system, and hence we have always looked at the sort of the demand coming into that system across both of the boroughs rather than borough by borough.
Again, there is no accident emergency in RBKC, so to sort of even it out based on two boroughs does make it difficult because those same.
Chelsea Westminster has an accident emergency in RBKC, so there is, and I'm taking the numbers which are presenting to any of our accident and emergency departments by residents who are residents of Westminster or RBKC between the ages of 18 and 65. They're the ones within the scope of this consultation.
Just kind of linking on from what Max's just said there. We've just been saying, but waiting times have increased in the last 2 years in A&E and RBKC, as shown on your page 70 in PDC. And you state that they're much higher than you would want them to be, and unfortunately, you have not been able to compare this data prior to the Gordon's closure. Therefore, you cannot tell whether the transport model of care with fewer beds but higher level of community alternatives is making wait times longer or shorter than the previous model. On this basis, how can we be confident if the preferred model of option 3, if you can't even conclusively demonstrate yourself whether this shift in services from inpatient beds to community alternatives has resulted in the rise in waiting times.
Yeah,
It just,
so
it just feels like it's sort of, there's not a great grounding that we're basing a seriously important decision on if you can't prove it yourself at the moment. And with that, in terms of the MCAS beds, how is that going to alleviate this pressure? Because that's not, I know what you're going to say, but it's more of a statement. I feel like doing that because I know what you're going to say.
Let me try and respond sort of briefly, and that's all Graham may want to sort of come in with the current position. So it is unfortunately true that we did not measure waiting times very well back in sort of 2018-19. We didn't measure them very well. It was very hard to do the comparison with today. So quite important. So hands up on that one, and that's the reason why we can't.
Which means there's no real evidence.
But this is the but. Whatever the number was in 2018-19, the number today is too high, and we need to get it down. So that is an absolute. And there are a number of ways in which we can get it down. Because ultimately, this is a question of flow and of capacity and flow. So how many people can we move through the system and at what pace, while ensuring that they get sort of clinically sort of appropriate treatment. And what the MCAS allows us to do is to treat more people intensively earlier, which means we can put more people into sort of community settings for sort of the follow-up of their sort of crisis treatment, and that increases our throughput and the flow which sort of comes through. Adding a further 4 beds to the MCAS obviously increases the capacity, allows us to do more with that, and tooling up those extra 4. Actually, they're not technically beds, but anyway, those extra 4 sort of rooms, for want of a better word, so to be able to take patients under section increases the types of patients we can take, and also allows us to move those out of sort of A&E sort of faster. So that allows us to do that. We then have, it has to be said, a bit of an issue at the sort of back end, where at the moment we have around about sort of 30 sort of residents who no longer meet our criteria to reside, and who are generally waiting for sort of non-health services to be sort of moved into. If we could sort that out, we would absolutely sort of deal with the problem of sort of people waiting for too long in A&E, but that is a difficult problem to solve. So that said, so Graham has been sort of running through the numbers more recently, the ones we have in the consultation.
Yeah, so the first point I'd make is it is appropriate for someone to use an accident and emergency department no matter what their health need is. And the vast majority, about 70% of those that go to accident and emergency that we would be referred to us to see have gone because of a physical health care issue. And what we are seeing is, and I think you've alluded to, Toby, that there are, our A&Es are busy places, and they're dealing with lots of demand, and that is contributing to some of the delays that we see. So we measure from the point of arrival at an A&E. I remember the A&E will then need to triage, assess, and then say, actually, we think there's a corresponding mental health issue, and then we will be brought into that pathway, and we will assess from that point. When we look at the total numbers of waits that we have, and we audit every single one, we look at them and we try to understand what has caused the wait in the hospital from a 4-hour and a 12-hour point of view. So we look at both of those. We see that about a third, if not, well, I'll look at it from the other end of the spectrum, about a third are delayed because of their physical healthcare treatment. That might be they've got a complex wound, it might be that they're intoxicated at the time, it might be that they have self-harm. All those sorts of things are being assessed and treated within the department. Then there's about a third that have other things that are causing delays. So you mentioned the by borough evening service for AMSA, that they are very busy, We're not going to take that away from, they're very busy and very important people, but sometimes we need to get an amp out or we need to get transport arranged. That can add to delays. And those that are actually delayed for a bed, it's again, it's about a third of the total number of waits that we have. So, and we what we're seeing and what we've been seeing consistently for certainly the last few months is that the numbers that are waiting for a bed that are being delayed is starting to come down in the right direction. But unfortunately, at the same time, the numbers that are delayed because of their physical health care needs is going up just a little bit. So it looks like a flatline top number, but we are seeing some improvements in the pathway for our patients. When we look at the MCAS, and just to respond to your point on this, so when we work in an A&E,
Sorry, we've got a really long agenda.
yeah,
And I know that you responded to some of that. It would be really helpful if we can just get to the end of this point so we can.
Sure.
Thank you.
the MCAS is not driven by the same clock that our acute colleagues have to work to, so we
Yeah, I
have
appreciate
slightly longer. We can see in our lighthouses and in our MCAS that those who we think are liable for an informal admission with that slightly longer assessment support, bringing carers and linking with the voluntary sector are much less likely to need bed.
Thank you. Just thinking back on some of the things you said around sort of strategic context and training for your staff in particular, and the move to the voluntary sector and what that looks like, and people being appropriate to support specifically acute patients. What does that look like in terms of funding, capacity building, that side of things, to ensure that people in the voluntary sector has the appropriate training in order to support people with acute mental health needs in crisis?
So in terms of where we've been involved then in this pathway, it's very specifically, so we've got the COPES, which is provided by Castile. That was a open tender process, and they have a particular experience of working there. So they make sure as an organisation they fully train their staff to provide a non-medicalised approach to mental health crisis, because for some people that is the most appropriate response that they're looking for. They don't want to actually come towards a system that they see as being more institutional and medicalised. So it's not the answer to every crisis by any means, but it's a piece of the jigsaw which is appropriate. So that they sit independently of the NHS in that respect. However, they have strong links with us and can refer you to us when they feel that their expertise can't meet what they need, and have a very good relationship with our crisis teams who can be very mobile, come to them and help out. In terms of where they would also work more in partnership, a good example of that would be in A&E, where we have a DCSE partnership with Red Cross. So they work very well with our people who have no recourse to public funds, and to have far more links into finding the right sorts of resources that can help people when they're in crisis. Quite often our A&Es are sort of beacon institutions where everyone knows you can go there and get help. Sometimes it's not really the mental health crisis as the foremost problem. It's actually the social crisis is the biggest issue at that point in time.
I'm being specific to the acute mental health crisis. We're not going to move away to the sort of, someone who has a mental health need and
absolutely,
not in
but that's the kind of thing where you will see it recorded in your A&E statistics, for example. This person's in an acute mental health crisis, but actually once an experienced liaison psychiatric nurse comes along, does a full assessment, they can actually say, well, actually, the fact that you have nowhere to go and stay tonight is the most pressing crisis issue. But actually, I'm not seeing the symptoms of other mental illness that's so pressing at this point. If we can resolve that issue with you, we can continue to link with you and work with your other issues in due course. That's a really good example of a partnership with someone like the Red Cross is working really well, because we're finding a much less restrictive option that's actually starting to resolve the highest needs that someone has.
So are you saying what's recorded as acute mental health crisis people turning up to any is usually not that, and they have a lower need?
I wouldn't be as broad brush as saying usually, but it's a subset of that group.
So excluding the subset, if we go back to
there are appropriate places where the PCSE do things better than we can in the NHS.
I understand
and we partner with them at those points, but there's always the expertise of the NHS to do the core assessment. And if somebody is assessed as having really high level acute mental health need, they will always have the services of the NHS available.
I want to be specific to the people, again, who have acute mental health crisis, not to the people who are then assessed and can be moved on into sort of community care. I want to be quite specific to them and what happens there.
So that's our job. We are the secondary mental health care provider for the residents in City of Westminster and not the BC. So we will be, but they are our patients, and it's our responsibility to manage patients who are acutely unwell. We can do that in an inpatient setting. We can do that with our home treatment teams. What we would then do when people move into more stability, when their treatment is optimized and effective, is we'll link them into their communities and the organisations that can support them with their own community needs moving forward. But we will be holding the very seriously unwell. We're not saying that we're using the voluntary sector, their sector, to do that for us. That's not appropriate. That's our job.
And around the sort of capacity building and training aspect, what does that look like?
So we have a team within the division that operates in our London Mental Health Services that look at our and support our partnerships in terms of capacity and development. So if there are opportunities for us to work on co-training or offering support, then that's something that we can do.
I mean, an example of that would be our home treatment teams are very engaged with the home treatment accreditation service. It's from our College of Psychiatrists, which is an independent body that will come in and review and assess the level of services that are being provided, the training of the staff, and they speak to the service users. So we use those independent assurance mechanisms so that we independently triangulate whether or not they staff the right levels, got the right training, delivering the appropriate model.
I don't think I've got my answer, but I'll move on from that point, just because we have a fair bit to still get through. And Councillor Arundel, I know you've got one or two thoughts around community impact on the residents specifically. So from that, do you want to?
I think you may have referred to it already. A large proportion of our homeless have mental health issues. So I think this does impact on that community. So I think I've already said that I think we need to look at them and engage with them and the people that work with them directly. They tend not to have carers, obviously, the rough sleepers, etc. But I think they need to be heard.
Yeah. Thank you. We'll carry on. I think it'd be a good time to bring in some of the voices of residents who are here and who would like to just talk a little bit about their experience. We're going to keep that short. Again, 2 minutes, hopefully you don't mind, simply because of our time and we've got some things to get through. Do we have any? Yeah, so if you introduce yourself.
Yeah. Hi, sorry about this. I'm not as eloquent as some of you guys. So I'm very involved in the community. I'm based on Clare. I've certainly been involved with Health Watch, and a lot of the people around here know me from my community involvement, as well as the local account group and everything else. We're talking about acute mental health services, and I'm hugely despondent as I'm listening. So I'm thanking all the councillors' input today, and we have a division here of what is reality, which we talk about best practice, we're talking about acute mental health, and then we're talking about what is being provided and what is very eloquently being offered, which in no way is reflective of the true state, which we need to listen to. I have attended numerous meetings, and I can honestly say across the acute thing, not just the meetings by CNWL, that has been from the AGM right across. I've had feedback from at least 130 minimum of suicide prevention meetings I've attended. And I have made it very clear to CNWL and the commissioners that the consultation has not been very public. It has been very poorly publicised in certain areas. It's been highlighted today. And I do think that there is unfortunately a north-south divide. I have banged on about it in my meetings as well. We have touched upon North Kensington, the Grenfell, North Westminster. However, there is a huge cohort of community residents that are not included in the south of Westminster. It's not just Pimlico, it's not just Mary Abbott Centre, it's not just St James's that you mentioned. There is Soho, there is Fitzrovia, there is the Strand, there's the basically besides near Leicester Square, that whole area. And there's a whole Chinese community, an Indian community, a Bengali community, and talking about the homeless, Westminster is one of the largest homeless groups. I was at a meeting yesterday for the local area panel, and homelessness was reflected at that meeting. Very eloquent person from the homeless. None of them, I raised Gordon Hospital issue at that meeting as well, because I felt it was important. And they were totally unaware. Certainly, we talk about best practice of patient-centered, local provision, service that they need according to the patient's needs, taking into the culture need. And yet we're trying to make a provision where someone has to fit in within the constraints. The criteria constraints is not limited, it's constrained. If you can't get access when you're in a crisis point because you don't fit the criteria, in the 21st century, that is shameful. We talk about patients that are going out of the area to be treated. That is not a sudden occurrence. It's been ongoing at the meetings that I've attended. Unfortunately, first-hand experience where patients have either, in one of the cases, and I think CNWL can back me up on this, the meetings have been very, very selective. They've been very north of the borough. The current meetings are taking place at CNWL St Charles's Hospital. There has been nothing in our area at all. It's been selective. We talked about today the voice exchange. I was involved for part of the voice exchange. I've certainly attended the meetings in my Health Watch capacity. It was a very small, select group of 10 people. That is not reflective of a major service, but it was a very worthwhile, and I felt the intention was really you were trying to sort something. It's not happening in reality, okay? Acute mental health means beds provision. If you provided a service where people, when they need the help, are not waiting for months, if not years, to access the service they need, we are going to have a crisis point where they need acute mental facilities. If you have a patient that comes in and requires services, you talk about MCAS, a lot of patients in the younger age group, forget when they get to adult, is not being helped in the manner they may have severe trauma in their family, and they have not been helped in order to overcome the trauma. This then, unfortunately, they fall through the gaps of it becomes the intermediary group, where they've got the 16 to 25 year, and then they fall into the adult services, and all the MCAS varies between the three different options when that happens. It then develops into self-harm and post-traumatic stress syndrome. So this is
30 seconds more, if you can.
Right. So when we talk about patients, the meetings I've gone to, one patient was sent to Bolton. The family had to take 2 or 3 jobs to access private support. When the patient finally in crisis was sent to Bolton, the patient committed suicide, leaving a family parentless and 2 children. The other service, when I say not publicized, was someone who came to a meeting in Kensington, because I've attended numerous meetings. That person heard about the meeting through the charity. A lot of burdens put onto the charities, and the facilities that are existing that is adding burden to already existing facilities. So that person didn't commit suicide, but that person was sent to Kent to facilities that were so dire that they felt like completing the unfortunate ideology. What we're missing the point here is that when a patient is referred out of the borough, the funding goes with that patient to the borough.
Thank you.
Lacking important facilities, first of all, duty of care. The funding is Westminster. The beds belong to Westminster. We have a huge demographic, twice or not 3 times the size of Kensington. It adds burden to all the neighbouring boroughs. And it's not fair to say that a patient has to go to Hillingdon when they're lacking the so-called community support. And MCAS is not what I call the intensive care that and the professional medical attention they need. I'm sorry, I'm not.
Thank you.
But
Your
you're
note been really well made. You have said it in a
and One UK
thank you.
also run a soup kitchen. Both, I must say, have offered to come to meetings. They said they have.
Sorry, Faye. Thank
Yeah.
you. I
But
think
if
we
you
are.
funded, I would be very happy to provide because the facilities have been very underattended. It's been very poorly advertised. It has been very poorly provided. And the people that should be attending, we need meetings where there's at least 60 to 80 people. So I'm feeding back to you what's been fed. And I'm sorry if I've gone over the top, but you need to hear the
I mean, your contributions have been really useful. So thank you so much. Is there anything that you might want to spend a minute feeding back on that Faye has said?
I'd quickly respond around the MCAS not providing intensive enough care. It's actually more highly staffed than a ward, and with staff who are more senior and more experienced, so we can actually provide more intensive support into the MCAS space. And that's a part of its success is being able to actually work really intensively with someone during that acute phase to find potential alternatives for them at that time.
And I just think I want to pick up specifically on the point of people who have been moved to places like Bolton, where it's added financial pressures and.
Yeah, so in terms of people going out of area, as we were saying before, that was happening even more back in 2018-19. And so I suspect a lot of these examples are from earlier there, because actually in the last year, we've been absolutely minimised the number of people who had to go outside of the CWL system to almost zero. So in terms of the system took a while to transform and move into a new place, and it was very bumpy there for a while. So certainly through 21-22, we saw a lot of people having to go out of the area. That wasn't good. That was unacceptable. But now that we've really embedded the changes, we're now seeing less people going out of area than we were back in 2018-19.
Thank you. That's really helpful. Just want to now bring in Professor Jill Manthorpe, and for you to.
I will try and be incredibly quick because it is late, isn't it? I just wanted to say how I think it's very helpful, isn't it, to have this longer engagement, and also not only longer, but wider, deeper, broader, whatever you want to say. And so I think that some of the points, hopefully, that have been made this evening will be picked up. And then that's very helpful. Of course, we do appreciate the knock-on effects. I think it's really what's come up this evening has been a great concentration on the local BCS, local voluntary and community sector, and how different that sometimes appears to be with the groups that you're contracting with, also described as being from the BCS sector. And it may be that there will be time to think about those relationships, people doing a lot of the work, frontline work, and then some other places that provide contracted NHS services who don't have perhaps that local community presence, and you might want to think about that. I think really money is always the big elephant in the room, isn't it? And how little mention in the consultation document there is about money. And maybe that's why there's this frustration around, because it's very generalised figures, 0.4, something like that million. And I think we've this evening had a lot more about the difficult choices, but to have greater detail on what those are. And when we're talking about staff being redeployed from the Gordon, how many? 2, 20, 300? Just being a little bit more crisp on that would help. And of course, staff costs go up, as we all know. So we've heard also a lot about new models of care, some of them increasingly about pilots rather than proven and evidence-based. One of the great things about having a pilot is it can turn out to be absolutely rubbish, so we don't do it. But perhaps a greater sense too much in the document that some of the pilots are being relied upon, and perhaps old practice was sometimes quite good. And then lastly, I think we just got round to talking about the MCAS, haven't we? And that was really, I think, very useful to hear about the extra staffing and so on. It's very difficult to follow that through, I think, in the consultation document. What does it look like? How do people understand its role? And I think particularly for the AMP service, understanding its legal basis, to have people who are in this slightly section, not section basis, and perhaps greater time to talk to the AMPs about the legal position of people in that service, and the impact, of course, on the staff who are the legally responsible for that, not necessarily employed by the NHS. So just to sum up, Chair, on those points.
Thank you. Do we have any questions for Professor Mantle? Okay. So,
thank you. And again, I'll keep it brief. But I do have just 2 key points I wanted to raise. The first, quite specific point related to the impact on community services, and specifically those working with homeless people. And I'm glad that that's been quite a prominent feature of the discussion today. But the one point I did want to reiterate is that if the transformed or semi-transformed model goes ahead, it will be absolutely vital that we create stronger links between the inpatient staff and the homelessness support workers. And this is something that we've heard again and again from homelessness teams, that they used to have very strong links with Gordon Hospital staff. This meant it was much easier for them to do forward planning. They knew about discharge plans ahead of time, and it just meant that that whole journey was much more cohesive, and that's not happening now. So just to see how that can be strengthened. The second larger point is really about the consultation itself. I'm really glad Faye was here today to talk about her experiences of attending the consultation, and other health watch representatives have also fed back points very similar to what the councillors have raised in terms of the suitability of locations, the number of attendees, but most importantly, I think the overemphasis on option 3 and the fact that residents haven't really had the opportunity to make any kind of meaningful discussion on the alternative options. And I think we would just like to feel assured that residents are making a meaningful contribution to the consultation, discussing all of the proposed options and not just heading towards any sort of foregone conclusion. So yeah, just to really reiterate what we've already heard about the consultation process itself.
Can you respond to specifically the consultation?
Yeah, so let's be on that one. So I think it is important to sort of reiterate that there are a number of different strands to the consultation, and the sort of public meetings are sort of one strand, as I said before, a necessary strand, but by no means a sufficient strand. They are, however, obviously the most visible strand, because they're the ones which sort of people can turn up to. And indeed, the sort of councillors have very eloquently made the point earlier on. So many of the people we want to reach do not naturally turn up and feel comfortable attending sort of those sorts of meetings. So I would entirely agree that the attendance at those public meetings has not been as high as as high as necessary to support a consultation. That is absolutely true, but they are by no means the only strand by which we are seeking that sort of residents' attention and resident input. It's also true that those meetings have been attended by a number of sort of professionals and other stakeholders in the system who find it easier to articulate their views in those settings than sort of some of our residents, which is probably one of the reasons why the residents don't turn up. So I wouldn't want sort of members to come away with the impression that we are relying on these sort of public meetings as the sort of primary vehicle for consultation. They're a necessary one. They are a particularly visible one. But as Ross has sort of read out some of the other streams, and we'll give you sort of more detail on that. But so those are almost certainly more important, because it's when we go and speak to sort of residents in settings where they feel comfortable, we are going to get better feedback than in the public meetings.
Just specifically to the written consultation that's online, that Councillor Butler-Bassett has described as poor bias. What do you say to that in terms of strengthening and improving that? And again, not just Councillor Bassett, I think we've had that echoed other places in the room tonight and previously.
Well, so obviously I would sort of reject the charge that is sort of poor and biased, and we put a lot of thought into it. We have sort of tested it with some sort of residents, sort of readability and sort of accessibility. And we sort of run it through our sort of lawyers to ensure that we are not presenting a biased picture, etc. So I can go through the list of sort of things we've done. So no, I would just not accept that the sort of document is sort of poor and biased. All of that said, it is absolutely incumbent upon us to be able to present to our residents in a format which they can sort of understand the sort of proposals which we are laying out, and sort of some of them sort of respond best to the sort of 30-page document, and some of them respond best to sort of other sort of forms of sort of communication. There's shorter leaflets and so on. So we've got a lot of thought into the different types of communication going to sort of different residents, some of them in longer format, some of them in shorter format, some of them sort of video format, and so on, in order to be able to.
Just before I pass it to you, Lucy, I know one of your concerns around specifically the MCAS and sort of what the new model would look like. And I think Lucy will ask that question, but specifically, if we can have something written, that a written report around what that would look like beyond just this saying the meeting's going to increase more staff and all these different things, it would be best to kind of be able to really see what that looks like. Lucy.
I'm going to ask these really quickly because I think they are really important to understand. And they will hopefully have quick answers. So sort of clarity on the number of cubicles and beds is in Appendix 17, there's differing numbers. So just an actual quick answer of what that is would be great.
8 beds currently in the MCAS, proposed to 12.
12 beds, okay, great.
They're not technically beds, but yeah, think of them.
In terms, I've got 3 more, but they're going to be very quick. In terms of have you understood the risks and the movement of the MCAS away from the inpatient centre at St Charles and having that co-location? So moving it away from there to the Gordon. I'm going to go through these quickly and then you can answer them. And then hours of operation. So the hours of operation are 24/7, but the consultant cover is 9 till 5 p.m. Will the MCAS have sufficient specialist clinical leadership during the 24/7 operational hours? And then in terms of self-referrals, if patients can self-refer to the new MCAS, they're in danger with demand and referrals, could they exceed the available capacity?
And just before you answer, if these answers are going to be quite long because it sounds like they need to be, then it'll be helpful if they are written in a report that we can look through.
Can I just make a comment on the MCAS, Chair? I'm sorry, it probably doesn't even answer, I just want to put it on the record. For option 3, which the preferred option from CNWL, what Councillor Knight rightly raised was moving the MCAS from St Charles to the Gordon. Now, I'm going to reiterate the Grenfell point. 72 people died in that tower, including 18 children. People's bodies, people's remains on that tower. Now, at some point, that tower may come down. It may not, but it may come down. And you're proposing to move an AMCAS that's based in North Kensington, where we have an international tragedy with so many people who have unfortunately died, moving that to somewhere that is not accessible or easily accessible for those residents, not just the bereaved survivors, but all of North Kensington, that's going to see that come down, potentially see those remains removed, which is going to be a traumatic experience for anyone, not just those people who live there, but for anyone. And we live it every day as councillors. You're proposing to move that to the Gordon Hospital. I find that absolutely bizarre. With a mental health crisis that may be coming even worse than it is now, to move that away. I just want to put that on the record.
Yeah, thank you. Really helpful. Thank you. Councillor Les, you're with us tonight, and I know that you're a mental health champion. I imagine you may have something I want to add to this conversation. Is there anything you might want to ask?
Hi, good evening. And yeah, I think that a lot of ground has been covered. I echo a lot of what councillors have said, particularly just as you said, actually about Grenfell. And obviously, in the Westminster Council, I've got a lot of connections and a lot of community ties to the residents in North Kensington, and I'm part of the Moroccan community within North Kensington as well. And I've got family friends who unfortunately passed away in the Grenfell Tower. So I think that that's a really, really important point to make, just around you know, it's quite far for the need to be available marketing. So how we're addressing that is really, really important. And then again, I know that we've touched on the appropriateness of how the consultation has been rolled out, but also how we are receiving those responses. So thank you.
Can we need some quick responses?
Yes, please
to
do.
Do you want me to, first one was.
I've written them down. So in terms of the risk moving there, yes, absolutely. We've considered providing more detailed reports. I think that'll take longer.
And also maybe including what Josh has just said.
The session facility coverage absolutely is 24/7 now at the moment, and it would continue to be so under new arrangements in the new area.
Okay.
And self-referrals for capacity versus demand, we've modelled that through. We can make that part of that report that comes through. The last point around the ground point, it's a very sensitive matter, and I think I'd rather provide that in some sensitive, measured way in writing rather than comments in the public here.
And there's no way, even if you went for option C in all of this, which is obviously not what we want, you could keep gas here as well.
It's an expensive model. There's no way we can duplicate that twice.
We do still, though, have a health district safety on the St Charles site, and our dedicated team are on the St Charles site as well. So there are still services that people will absolutely access, and it's right for them to access on the St Charles site. What we want to do is also think about it through our process of pre-engagement and consultation. There was a very real concern about services available in the south of Westminster, so we're trying to balance the provision and the excellent provision we have in St Charles with some enhanced provision within those communities.
Last question on the MCAS. How long would it take to refurbish it as an MCAS? So if this consultation ends and you go with the option you want, how long is that?
I can give a figure on that right now, but we will move to make that as quick as possible. We don't think there's a lot of structural need within that space. We think we can make it work, but we'll get a response.
Just sort of final thoughts before we go, right? Just as you're both here, something specifically around social care and looking at that and the impact on social care with not having mental health provision in the appropriate way.
I think what would be best for the committee is to hear directly from the relevant staff and the relevant services. I would advise to hear from our AMP service, from the police, and from the A&E in St Mary's, and from the housing in Westminster and maybe now KC. I think they would give you much better responses than I can secondhand.
But I agree with Nasica as well. I mean, there's going to be an impact, a social care impact. And that's going to put further pressure on our own services as well, which is what I mentioned before. So that's unquantifiable at the moment, but I think it definitely will have an impact for
Thank you. We have moved our agenda around, but we're now at the end of the agenda. Before I close, do any members have any other urgent business to raise before I close the meeting?
Close it quick.
Go ahead.
No, I just said close it.
Oh, okay. I thought you said you had something. Okay, so I'd like to remind everyone that the next meeting is scheduled on the 23rd of January 2024, and I will now formally terminate the meeting. The time is 8:42. Thank you. Thank you.